Good day, listeners. Welcome to Ausjdocs podcast episode 4. I'm your co-host Andy. We are back with another awesome episode. Our special guest today is Edie Girl. Obviously, that's a nickname to protect her privacy. She is a friend who's currently working as an ED senior registrar in Victoria, and she'll be sharing her personal journey as an emergency medicine trainee. Let's get right into it, shall we?
All right, everyone, welcome. So we have a special guest here today. So she goes by the anonymous name ED Girl. She is a emergency training registrar. And we also have Andy here. Welcome, everyone.
Yay, welcome Edie
Hey,
Girl.
thank you.
Hey, Andy, you weren't here last time, man. What happened? We missed you.
Dude, busy bro, busy.
What have you been doing?
Busy with
You're not
work.
that busy though, man. Yeah. No, but Andy had to work over the weekend, so yeah, he couldn't join us for the ENT episode. But yeah, he's here now, which is good, right?
Yay!
Right.
All right, Edie Girl, welcome, mate. How you been?
Yeah, great. Yeah, I haven't talked to you guys for a long time.
Long
Yeah.
time, mate. It's been, I would say it's almost been 10 years, I reckon.
Nah.
Yeah, I think
Which is
so.
6, 7 maybe?
6, 7? I don't know.
Okay, yeah. Because we knew each other back in when we were interns, I believe.
No, I think second year, I think.
Yeah, we were intern and you were PGY too.
Oh,
really?
yeah, right.
Yeah, I was JHO, and actually, I didn't know you guys were interns back then. I thought you
Oh,
guys
did
were
you not?
I remember you as the cranky JHO.
What the hell? I was never cranky.
You were cranky during a ward call.
Really?
An evening ward call shift. I was like, oh jeez, I better watch out.
Yeah. Hey, but that bloody pager went off all the time. It's
Yeah,
like,
but like,
That's true.
remember?
Yes.
yeah, to be to frank, that job is pretty, it's not that great, right?
Yeah,
Holding the
I
pager and
agree.
everything else. Yeah.
Yeah.
And that was, one of the hospitals in Queensland, and you were basically covering all the wards, I believe, wasn't it?
Yeah, during nights, I think there were 2 of us, and then
I think there was 2. Yeah, it was an evening ward call, and it was divided between like one side and the other side, I think. from memory.
yeah, and then you get like so many pages throughout the night. I couldn't even finish it. That's why I was like so cranky.
This was back in the day where we had to recharge all the meds, and like the home team doesn't do the recharge during the daytime, and then they call the ward.
Oh my God. Yeah. Yeah. Yeah, all paper form as well.
Anyway, ED Girl, let's have a let's go back and talk about you. So again, are you an undergraduate or postgraduate?
I'm postgrad.
Oh, okay.
You're postgraduate. What did you do
Yeah.
before?
So I did actually Bachelor of Science in Animal Physiology, actually.
Oh, you wanted to be a vet, did you?
Wow.
Well, I had my options open, and then, yeah, somehow I ended up in medicine instead of.
Close enough.
Hold on. So that bachelor, Is that a veterinary science or is it something different?
Yeah, so it was Bachelor of Animal Physiology. Back in I got it from Canada. It was in Queen's University.
Oh,
Yeah.
wow.
Queen's University in UK.
No, in Canada.
Oh, in Canada. Oh, you're from Canada.
Yes.
Wow.
You didn't know that?
No, I
Do you guys know each other?
That was yeah. I mean, like,
Great. It's been a long time. I'm
yeah, it's been a
sorry.
long
It's
time.
yeah.
That's true.
Yeah. Wow.
Yeah.
So what made you change? You know, what made you think about getting to med?
So I think I was starting masters at the point, and I was stuck in research, right?
Oh,
Doing all the
Mm,
experiments. And then
mm,
one day it hit me. I'm like, I'm not really making any change to the world as what I really was hoping. I'm like, I wanted tangible results in my work. And
right.
and then I was like, you know what? Maybe medicine is what I should be doing instead of
Gotcha.
pipetting my life away in the lab. So I was like,
Right.
yeah.
Did you go to medical school in Canada or in Australia?
No, in here, Australia. So I went to
In Australia. Okay.
University of Queensland. Yeah.
Okay. So as an international student.
Yeah, yeah.
oh, you were my senior then, Edie girl.
Oh.
Oh, wait,
Oh,
you went to
interesting.
UQ as well?
Yeah, I graduated 2014.
All right.
Yeah.
Okay.
Are you sure you guys are friends? Like, how do you guys not know each
Oh,
other?
it's a big cohort, mate. It's like 500
Yeah,
people or something.
yeah, it's
Yeah.
like crazy.
Yeah. It's getting bigger, I think.
Is
So
it?
they're
Okay.
taking more more medical students in. Anyway, yeah. And how was that med school? How was the med school life for you?
I remember UQ PBL. Do you remember, Andy?
Yes, yes, yes.
Yeah. Oh my God. It's what does it stand for? I forget. But
Problem-based learning.
Problem-based learning. Yeah.
right. To be honest, I don't know. It was mostly self-learning for me.
That's it. That's it. It's a self-directed learning degree. Yeah. So you basically
Yeah.
it's like teach yourself medicine, pretty much.
Yeah. Yeah.
So they basically tell you to study by yourself, but they charge you about 300K
Pretty
to get the
much.
degree.
I know.
Okay. Anyway, so yeah, so you graduated after 4 years, right? It's a postgrad degree.
Yeah. Yeah.
And you were doing some internship and residency in Queensland. Have you thought about doing ED at the time when you're doing an internship or a residency?
No, not at all. In fact, actually, I was a really bad ED intern.
Right.
So, to me, it was the hardest specialty because it was way too fast paced for me as an intern. Because like how interns are like. You guys remember when you guys were intern? You have
Yeah.
we had a lot to learn at the beginning, and I felt like
Yeah.
ED, it was way too fast and you see way too many different presentations. So I think, yeah, I never thought that I would be doing ED, to be honest.
So when
Just,
did you decide to, oh, I actually am interested in doing emergency medicine as a career?
Yeah. I think PGY 4, I think.
All right. So just tell us
Yeah.
Because
what you did after PGY one, because we haven't met for a long time. We haven't
Yeah,
talked
so
for a
Yeah.
long time.
internship, after internship, I was JHO with you guys at the hospital. And then I was a SHO in actually orthopedics.
Ah, right.
Oh, I remember this.
And
Yeah, you
then,
actually wanted to do orthopedics before, right? Before
yeah.
getting to ED.
And then fourth year I was unaccredited ortho reg.
Yeah.
And then that's when I decided I should be doing ED. So fifth year, I actually had to become ED HMO again.
Right.
And
Okay.
in sixth
Yeah.
year, ED reg. Yeah.
You would have been a badass ortho Reg, though. I reckon. You would have been, yeah, you would have been a really cool ortho Reg.
What you
Because think about it, like
badass?
not many female doctors do ortho, right?
True.
It's really a like it's pretty much male dominant field, ortho.
I think
But
so now there are a lot more female orthopedic registrars
there is,
compared to
yeah,
before. But
and consultant as well.
yeah, but when I was one, I think yeah, there were not that many.
What were the were there a bit of a challenges or the things that you didn't like about ortho that you had to pivot back into ED?
Yeah, I mean several.
Mm.
So being on call was actually quite difficult for me.
Mm.
So you had to work all day and then you're on call. So technically,
Jeez.
you're expected to still, if you get called in during that, you're still expected to actually come to work the next day to present in the trauma X-ray meetings, and then
Yep,
you're still expected
been there,
to.
done that.
Yeah, you guys remember all this. So that that lifestyle was actually quite challenging for me. Also, people say like if you have the right techniques, things are easier in orthopedics, but I think still you need to have certain strength to certain procedures. Like, for example, like even like reductions, like, you do need quite a lot of strength to do that. And if you do more than like once or twice per day, that really tires you out, I feel like.
Yeah. You need muscles for ortho, hey?
Huh?
Yeah, exactly.
Yeah, exactly. Yeah,
You,
that's how I feel.
I was assisting one of the, I think it was total hip or total, I think it was total hip anyway, and I had to hold the whole lower limb.
Yeah.
Oh my god, it was so heavy.
Yeah.
I was holding it for like 2 hours or something, and I was like, dude, this
Two
isn't.
hours.
I don't want to do this.
Yeah, no, that
It was great. Yeah.
yeah, no, I agree. I mean, like,
Mm.
yeah, definitely, it's tougher for I think women. Yeah.
Where did you do this ortho unaccredited reg job? Was this still in Brisbane or was this in Victoria or New
No,
South Wales?
no, it was actually regional Brisbane without
Oh,
saying
okay.
specific hospital name.
Yeah.
But, yeah, and then I moved to Victoria for ED training.
Oh, so you got onto ED training and then you moved to Victoria for ED, is it? Oh.
Oh, so what happened was because with all the orthopedics, of doing it for 2 years,
Yeah.
I actually even forgot how to look at ECG.
Ah, yes, of course.
So,
Typical ortho reg.
JP
So I
still
had-
asks me how to read ECGs to this day. So.
Oh, really?
No, I don't. What are you talking about? Dude, I know how
True story,
to
bro.
read.
True story, bro.
Mate, I know how to read ST elevation. Okay, that's it. That's all I need to know. Whether it's elevated or not or depressed. That's all I need to
Oh,
know.
so yeah, I actually started off doing ED HMO job, which is like equivalent to like SHO, I
Yeah.
think. So here, like they call like HMOs, it's like resident. Yeah. So I did that job for 1 year and then I applied to ED training and then yeah, like and then became ED rich after.
And how do you find that? Like, I guess pivoting back from from orthopedics to ED.
Mm,
Obviously, it's a different environment, different settings. How did you find
yeah,
just changing
initially it
and
was
going
very
and even going to a different state as well, isn't it?
yeah. Initially it was quite challenging because orthopedics, like how you do your ward round, morning like trauma meeting ward round, it's quite structured and you have clinic and you have theater. So getting adjusted to ED life was a bit tricky because it's shift work and not only that, like knowledge wise, I had to like learn everything again. Like I
Yeah.
said, like ECG, like blood tests, and like doing different procedures in ED. Like
Different
I
skill
wasn't,
sets required, hey?
yeah. So that was a bit tricky at the beginning. That's the reason why I had to step down as a resident first to gain all these skills because there was no way that I was gonna be a registrar back to back from orthopedics to ED because there's a lot of different like knowledge gaps in between. Yeah.
And but how are you? I guess mentally. So obviously, it's a bit hard to. It takes time to pick up those skill sets again.
Mm,
But were you a bit more? Obviously, coming from the trauma meetings and busy environment,
mm,
lack of sleep.
yeah.
Coming into another environment, was it a little bit better for you mentally, or how do you find that?
Mm, I think shift work works better for me, but
Okay.
at the beginning it was more of just like getting used to different skill sets. I think that was a bit tricky.
Mm,
But
mm,
no, I think I was okay. But initially it was, the thought of like being a registrar and then you have to step down to like a resident. That was a bit
mm,
tricky for me, but
mm,
that was
mm,
needed. But it
mm.
only took 1 year or even less than a year, I think. And then I stepped.
Yeah, I reckon. Yeah, you can pick up pretty quickly though. Like a couple of months, I reckon you can do it.
Yeah, so at the end it worked out okay.
Mm. And how you find the training program now?
Mm, yeah, good. Yeah. I mean, there's always
It's better supported than orthopedics though, I think, isn't it?
well, orthopedics, I was on unaccredited reg, so I wasn't on the training program, so I can't really comment what it's like to be unaccredited ortho reg, to be honest.
Yeah.
But yeah, like as an ASIM trainee, yes, well, each hospital, I think they have what do they call like DMT, which is essentially
The director
the
of medical training.
yes,
Mm.
that's right. And they help you to, transition through your junior year to seniors in the program. So help you with the studying for primary and fellowship as well. And if you have any problems, they're the go-to person to speak to. Yeah.
That's interesting. I don't think we have that. In, well, I don't know. I actually have never met anyone who does that in surgical areas or any surgical units.
Oh, so
To be
surgical
honest,
units, you guys don't have it.
you're on your own. You gotta read. You
Really?
gotta pretty much.
Okay.
Yeah, you gotta
Figure it
pretty much
yourself.
look at the. Yeah, you do it yourself. You gotta do your own. Learning, studying GSSE.
Mm,
You're doing your own research.
yeah.
Yeah, it's I don't think there's yeah, I don't know. It could be just me, but yeah, there's really not much of a support there. And
Right.
that's another story, but yeah.
Mm,
Hey, this is actually a good point. So one of the listeners' questions was that what are the average hours or the typical roster makes up both as a registrar and later on as a consultant?
yeah. Good question. So, full time, we go by what we say 1.0. I don't know what the system is like in Brisbane, but yeah.
Same, I
So
think.
yeah. So 1.0 is full time. So if you're full time ED ASIM trainee, you'll be working 4 days a week, and that will be 9.5 hours per shift. So you could be getting, AM or PM shifts or night shifts. But when you're doing night shifts, it's usually 10 hours. Yeah.
Yeah.
Okay.
So it's a bit,
They're normally normally 10-hour blocks, aren't they? All the shifts in
yeah,
emergency.
9.5 to 10 hours. Yeah.
How frequently do you have to do unrostered overtime? Like at the end of your shift, that sort of thing, having to
Uh,
sort things out after handover. Like how frequently does that happen? Does that happen most of the time or less than 50% of the time or very infrequently?
I would say probably less than 50% of the time
Oh, that's pretty
because
good.
yeah, usually what would happen is that you would be trying to sort out all the last minute business in the last 1 hour. So you're not picking up any new patients per se in the last 1 hour. unless there's like a really sick patient that you would need to put your name to and then help out. But yeah, generally speaking, like people will be sorting out, last minute jobs in the 1 hour so that you can get home on time. But if you're senior reg in charge during night and then you have to listen to all the junior doctors hand over and then because you have to wait for all the junior doctors to actually hand over before you, right? So that when you're doing nights as a senior reg in charge, then you get off late. That's usually what happens. So I would usually finish, I think on average, maybe 1 hour later than what you're rostered for, I think.
Yeah, so we've been talking about the average hours in typical rosters in emergency department. I mean, from my experience, I think it is actually pretty good in terms of keeping up with your shifts. So even before, like 30 minutes before, if you're a resident or registrar, the consultant will tell you to like pack up and summarize and don't pick up any shifts or sorry, don't pick up any other patients, and you get to just finish up nearly on time, right? Normally
Yeah,
as a
Depends
resident.
depends how short-handed the department is at that particular day, I suppose. I think.
But I mean,
Yeah.
when you compare that to a medical registrar or a surgical registrar, they're pretty good, I reckon. They have a good support there, don't they?
I think so
Yeah.
too. Yeah.
Because like you always have say for example, if you're finishing as an AM shift, you always have like people in PM who can take over the patients. And yeah, like generally you will get out on time. Yeah, unless like
Oh, sorry. And I was just going to say, so when you actually do a handover, sometimes some ED departments, you actually get to sit down with everyone. So people coming in for a shift and people getting out of the shift, and they can like do a handover, room, like so everyone understands with a consultant. Was that the case for you, or was it something different?
no,
Okay.
I actually remember doing that when I was at the hospital that we used to work together.
Yeah, I like that.
Yeah, yeah, they don't do that anymore. I mean, they don't do that at the current hospital where I'm at. So
Right.
you would be basically you'll be handing over to the consultant in charge
Oh,
during
okay.
that time, only to that consultant. So you would not be talking in front of like, like 20 other
Everyone.
people in the room. Yeah, like remember how we handed over at that certain hospital? Like, yeah,
Yeah.
it doesn't happen at other.
Oh, that's interesting.
It's more efficient to do it one-on-one, I suppose, because then it can happen simultaneously with all the stuff coming on, and instead of
Exactly.
one person
Exactly.
speaking and everybody listening
Yeah,
at any one time. Yeah.
it's way more efficient that way so that, specific people can just find, certain consultants and then hand over and then go home on time. Yeah.
So as a resident or a registrar, obviously you have night shifts, and I guess that's one of the big things about doing emergency. So what's the ratio like doing, whether you get a day shift and a night shift, and
Mm,
with that, and also like how many rest days do you get afterwards? Is there like a certain ratio?
yeah, there is. So I think as a registrar in general, you get rostered, but like it's different between junior registrars and senior registrars as well. But as a junior registrar, you get rostered per nights less
Okay.
because you have more junior registrars to cover for night shifts. Whereas for senior registrars, you basically get rostered on about every like 2 to 3 weeks for night
Okay.
shifts. And one go, you will have about 3 to 4 night shifts at a time. Yeah.
So basically, 1 in 3 weeks is night shifts for you
Yeah. Yeah.
at
That's
the
correct.
moment. Yeah.
Yeah. Yeah.
Okay.
Yeah. Yeah.
And then how many rest days do you get after those shifts?
Um, generally about 3 to 4 days if you're full time. But currently I'm actually part time. So I'm 0.75. So I
Okay.
get more days off. So think like for me at the moment, like 5 days off or something like that.
Okay, so just for the listeners, when we talk about 1 FTE or zero point 0.4 FTE, the FTE means full-time equivalent. So that's just a term that we use as well.
Yeah. Yeah.
Um, but so that's a registrar. But when you become a consultant, it must change, right? They don't really normally do much night shifts as a consultant.
So they don't do night shifts at all, actually, as a consultant. So they are on call. If the senior registrar needs extra support from the consultant, that's when they get called in. But generally speaking, yeah, they're not rostered to work night shifts as a consultant.
And they only, I guess, it's quite rare for a consultant to come in. It's only really for emergency or like if the resource space filled where you need to deal with like, emergency stuff or traumas and things like that, isn't it?
Yeah, that's correct. That's correct. Because you also have, other extra support in the hospital. So generally speaking, like you would not call the consultant on call unless, yeah, things are really dire. Yeah.
And you mentioned that there is a junior reg and a senior
Mm,
reg. What's the
yeah.
what's the difference? Is a senior registrar is actually working on the whole floor, like managing the whole floor of the emergency department?
Yeah, that's correct. So, junior registrars, so the level amongst the junior registrars can vary significantly. So, a junior reg can be like first year registrar who would be generally like PGY 4. But they have not done any critical care terms or they haven't really been exposed to many specialties. So sometimes the line varies between an HMO and a first year junior reg.
Right.
Whereas at the end of the spectrum, you will also have a junior reg who's called a junior reg, but they're more like closer to senior reg, but they're not experienced well enough just yet to run the floor. Because in order to actually run and manage the ED floor, you have to be at a certain level, you have to be able to multitask. And because what generally happens as a senior reg in charge during night is you'll get a lot of nurses and junior doctors coming to you with different questions at any point. And you will be able to manage all the, different things going on at certain time. And also not only that, of course, you will have to be able to manage all the resource sick patients, critically ill patients.
So basically, you're the most senior person on the floor. Basically, if you're a senior registrar, and you have to give support to everyone, basically the residents, junior regis, and even nurses, because you're managing the whole floor by yourself. Basically.
Yeah, that's correct. And then you have to liaise with the ANUM, who's actually the nurse in charge a lot during the night. It's not just about also like taking care of sick patients in ED, but it's how to actually manage the floor for, say, example, if there's no beds whatsoever, what we call the term bed blocked. You need to try to somehow make the situation better. And you have to know how many patients are actually sick in your department and how many are waiting that are not sick that should be going home soon. So yeah, just overall everything.
Sounds very stressful.
Yeah, it's very stressful.
Yeah, I mean, for me, like transitioning from a junior reg to senior reg, I think was the most stressful part. Because as a junior reg, all you have to really care about is your own patients.
Yeah.
So you don't have that responsibility upon you to, like see what the department is doing. But I think as a senior reg in charge during night, your responsibility is not just your own patients, but it's also all the junior doctors' patients plus also
The patient
how.
flow. Yeah.
Yeah, exactly. Yeah. Right.
So I guess you kind of need to know how to read ECGs then.
Yes. Yeah. I had to
You must be really
learn
good
that
at it,
all
though.
over. Hmm. You have, I know enough to,
No, I'm sure you do. Yeah, no, I'm
make sure
It's
sure
that
you
I
it's
do.
don't
it's
miss.
all it's all about pattern recognition, JP. So
Exactly.
once you've seen enough of it, you can just recognize it, and you don't have to think about it.
Yeah.
Okay, yeah, easy for you to say, Matt, right?
Kind of
Yeah, don't really care. I don't really care. But hey, so this topic is really relevant for you, ED girl, because you're in Melbourne, and recently we hear about all these bed blocks and ramping up, especially in Melbourne, because it sounds like it's been
yeah.
hectic in most emergency departments in Melbourne, right? How did you find that?
Yeah. Yeah. Oh my God. So I think during COVID time, so you remember like during actual pandemic,
Mm,
there were actually not that many patients coming to ED because people were so scared to catch COVID.
yeah.
Funny enough, during that time, so ED was actually not that busy during like actual lockdown.
Mm,
But I think pandemic, like pre-COVID plus also post-COVID, I think it just got really busy. So the general wait time in ED would be anywhere from like I would say 5 to 6 hours at the point, or
wow.
sometimes worst case scenario you would have like days when you start your shift and you see like a 9 hour waiting.
Mm.
Yeah, in ED as well.
Oh, like is that a cat 3, cat 4, or cat 5
Yeah,
that's waiting for 9 hours?
usually Cat 3, Cat 4, Cat 2s have to be seen.
Yeah, pretty
And
quickly.
yeah, so generally Cat 3, Cat 4, but they've already blown out of time, of course, 9 hours.
Yeah. Sorry, is the hospital virtually bed blocked all the time?
Absolutely. So I don't think we have a single day where actually at the moment we don't have any days that's not bed blocked. So what would happen is that if there are inpatients, so patients coming in constantly, but there's no beds to actually place the patients, right? Which means that we're only left with seeing patients what in waiting room per se, or in these cubicles that's not really nursing staff.
Yeah.
So where the doctors have to actually take their own bloods and then
Yeah.
like take history and do examination. But those
Yeah.
cubicles sometimes they don't even have beds. It's only like only one single chair there. So they're not really designed to do those things. And we are actually,
So they're ramped up as well.
yeah.
Makes it a lot
So
more
it
challenging.
Mm.
just, yeah, gets really tricky. And, yeah. And not only that, like many doctors call in sick as well because they catch COVID or they have other viruses. And you're supposed to have like,
Mm.
let's see, probably 7 or 8 doctors per shift, I would say. But sometimes you would have half the staff because they're all like cold and sick.
So if you had to outline the problems that you are facing, is one, so staffing issue. So there's not enough people. Increase in patients sound like, whether it could be because of COVID, influenza, or all sort of things. Are they the main issues, or is there something else as well on top of it?
I'm sure there are also other issues, but those are the major issues that we are experiencing at the moment. And also,
Mm.
we see a lot of patients that have chronic problems in the community that come to ED for, you know, things that could be dealt in GP clinics.
Mm.
I hear this a lot from patients. They tell me, oh, I try to book an appointment with my GP, but my GP is completely booked. So the only way I could get this resolved by coming to ED. So I hear this a lot from patients. Um, yeah.
And here is a GP registrar, just to remind everyone. So I'll let him rebut on this case as well.
No, there's nothing to rebut. GP is chronically underfunded by Medicare, and that's why you're struggling to get
Yeah,
in to
I
see
think
one. That's the
ED and
problem.
both GP, we both are struggling because we're short-staffed and underfunded as well. So
And I guess the solution from there is let the pharmacy prescribe and give medications and diagnose. That's probably the best way.
that's what was proposed, right? I think there's a lot of there could be a lot of problems with that though.
Well, they're not just proposing it; they're doing it. So the New South Wales
Are you?
is probably going to do
Oh,
it as well. Queensland had a trial in
really?
Far North Queensland has already done a trial. Yeah.
So JP is obviously being
Yeah, I am.
sarcastic.
Yeah, I am. Yeah, I
by
am
that.
definitely being sarcastic.
Okay, good.
Yeah,
No.
yeah. But there has been another news where I think they're thinking about, especially in New South Wales, they are letting the medical students get paid and just help. How much help do you think you're going to get from a medical student in an ED or emergency department?
Oh, actually heaps, because especially the ones that can cannulate
Mm,
or do ECG,
mm,
and also if they can scribe, I think that will be very
mm.
helpful. Yeah.
I think that's actually a better idea than other non-medical doctors. You know.
I think it's a good idea because they eventually will become part of the workforce.
Yeah.
So whatever time you spend training them actually helps in
Mm,
the future because they'll be more efficient and more
mm,
skilled doctors in
mm.
your
Yeah,
workforce.
I agree.
And it's going
Yeah.
to be a symbiotic relationship because medical students has more exposures to learn in a real environment, and also
Mm,
doctors, residents, and registrars are getting more help. Yeah, which is it's great. It's actually a great idea, I think. Um,
yeah.
and also, I believe in Auckland, in New Zealand, they were doing it for like many years ago. Since I think so, they get paid as a final year medical student, I believe. Um, but yeah, I think that's a really good idea to do that. Um, let's go back. So let's talk about the ED training itself. So when can you actually apply for ED training, and what are the hurdles?
So I believe you can apply for ED training as a PGY3 to get onto the program as a PGY for registrar.
Mm,
But you do need to have completed, I think, 6 months of ED previous experience,
mm.
and you do need to also have certain different specialty requirements. I don't know those specific specialty requirements at the moment, to be honest, from top of my head.
That's okay.
But it's
But sounds like you need to be in a critical care rotations. Basically, you had to do an ED, obviously.
yeah,
And it would be a plus if you did anesthetics and ICU and things like that as
yeah,
well.
that would be definitely. And then
Mm,
need I believe 3 references. Plus
mm,
they have an interview, I think, where
mm.
and which includes also an assessment, which is a new thing. Because when I applied, they didn't have an assessment
Oh.
part of the interview. But I heard from
Okay.
the people who actually got into the program last year, they had to do it's like an exam slash assessment during interview, I think.
Is that a like state based, or is it like a national, or is it just hospital based?
Oh, it's national. So, because the
National.
college
Wow.
itself
Okay.
is actually, yeah, national. So yeah,
So it's now mandatory to pass that assessment
I
in order
think
for you
so.
to.
Yeah, I think that's what
Right.
I've been told by the
Okay.
ones that got in.
Is it still relatively easy to get on? Like what are the proportion of people who get onto the program
Yeah.
Mm.
as opposed to like the total number of people who apply to get on?
To be honest, I don't have the exact values, but
Oh, just
I,
Just
based on
roughly. Yeah.
anecdote, just
but
roughly.
most people that apply, they get on. I think
Yeah,
the
okay.
occasional that I would hear, they don't get on. Um, but like, yeah, it would
Mm.
be, I think most people that like amongst the HMOs who wanted to get onto the training program, like ASIM, they mostly got it. Yeah.
I think it's part of it because they probably do need more junior doctors in emergency compared to other specialties. I think they need a lot of doctors in emergency anyway. So
Just like GP, everyone who applies eventually get on.
Yeah. Mm.
GP, yeah. But other question actually I have is I think there's a way where some GPs or or even residents who wants to get on, they do diploma. Like there's an ASEM
Yes,
diploma.
that's
Do you know
correct.
about that?
It's
Yeah.
called EMC, so Emergency
What is that
Medicine
about?
Certificate. And
Mm.
I do have friends and junior doctors who actually are doing it at the moment. But what I heard is that, so yeah, as a GP or residents, they can actually get EMC accredited. And don't quote me, but what I think is that they can actually work in regional with that in ED setting as well
As
as a
a
GP or so as a CMO.
right,
Yeah,
okay,
but
okay. So uh, just to clarify, so once you do the diploma, like for example, as a GP,
yeah,
you can effectively work as either a senior ED registrar or even a consultant level
I
in a regional area.
don't think as a senior radio consultant level, to be honest, but probably somewhere equivalent to registrar, I think.
Okay, because
I think it
you,
depends on how desperate they are for doctors.
Yeah,
You know that back in the day, we had like GPs running the emergency departments in some rural/regional hospitals.
yeah,
So
yeah.
it depends, I think.
well, no, when
But
remember when we were doing emergency in our hospital, we had a GP, so we had a GP consultant who was overseeing
At the hospital
the
that
hospital that we
we
worked
worked
in.
in.
We worked in, yeah,
or
yeah.
I think they were grandfathered into the system. They were already part of the system when that happened. Now that there are a lot more FACEMs coming out of
Okay.
the system,
Mm.
that's less commonly seen in the metro hospitals,
Yeah,
but you probably still see that in the regional rural hospitals.
yeah.
Okay. Okay.
That's true because then even in regional nowadays, you see way more FACEMs now because like what Andy said, there are way more FACEM yeah, fellows coming through.
Hmm.
So
And I guess this is a good time to ask the listeners' question. So they were asking about the job market for emergency medicine. They did hear that there's a lot of like negative things about it, and I'm guessing what they're saying is, there are GPs who can do emergency, like we said, when you get that diploma, and it sounds like there isn't much jobs available for a consultant in the metro area, and they're kind of pushing out to the rural regional areas for a job as well. So do you know a little bit about that? And can you tell us about the job market as
yeah,
a consultant?
so most people that actually pass the fellowship, so all the ASIN, FACIN like fellows, they so amongst them, I don't know a single person that has not been hired as a consultant. So
Okay.
most people that pass the fellowship, they will have a consultant job, especially within the same network that they worked with as a registrar,
Mm.
if they have a good record with them, especially.
Mm.
Mm.
But that's important though,
Mm.
because if you've been hardworking and they value you as
Mm.
part of the team, then they'll likely to retain you. But I have not seen a
Mm.
single person that's passed the fellowship and not with a job.
Did not get a job.
Yeah.
Yeah.
But would they get an outer metro job or
No, I think most people actually get jobs within the same network that they worked, but um, they're actually in terms of the job market, ED at the moment, at least at the moment, it's not that bad because if
Mm.
you also consider private hospitals as well
Mm.
and
uh,
regional, there's heaps of work. Regional hospitals, yes, they are very desperate to get more FACEMs at the moment.
Okay.
Yeah.
So say for example you fellow into one of the metro network hospitals and you become a consultant.
Hmm.
Do you always get a one FTE jobs,
No.
or because there's so many doctor
Yeah.
consultants already, do you only get like 0.5 or 0.7,
That
whatever?
Yeah, I think so. They normally don't get 1.0, which is full time. They would generally get 0.5. I think in rare cases they do get full-time, I've seen. But generally speaking, I think they get part-time, 0.25 or 0.5, and then you will have to make up the other half by working in a private hospital or a regional. And sometimes
Okay.
it's better to do that actually, because you get less mental load on you by working in a regional or a private hospital. Yeah.
Right. Okay. Right. That's interesting because that kind of sounds like because it's metro. I mean, I'm sure if you go to rural area, if you want, you'll probably get one FTE, I guess, because they probably do need doctors there anyway. But just going back to the training program, so ED training is 6 years, isn't it?
It's minimum 5 years.
5 years. Okay,
Yeah.
so even 5 years, it's quite a long time. How are you finding it in terms of the years and I guess the leveling up during those years?
So I actually set my primary exam in my first year as a first year registrar, which I highly recommend to everyone because the longer you leave the primary exam, I think it's difficult to study for.
Okay.
There's a lot of basic sciences on it, right?
Yeah, exactly. So I felt like I was going to med school all over again because, you have to go through even that, what do you call it? The Krebs cycle and
The
all
Krebs
that.
cycle.
Oh my gosh.
Oh, geez, really?
Yeah,
Biochem?
yeah,
Wow.
part of it. And like remember all those things like um what is it? Like all the all those like little physiology, pathophysiology.
All the potassium and sodium channels and
Yes,
whatnot.
yes, that too. So that's all part
Okay.
of primary. Yeah.
Right, because um, I guess surgical, like the GSSE, which is a surgical primary exam, they have three components basically. So it's anatomy. Obviously they have a quite emphasis on anatomy,
Yeah.
pathology and physiology basically.
Yeah.
But sounds like for an emergency, like you guys are even doing like biochems and those foundational kind of
Yeah.
medicine as well or science.
Parts of
Wow.
biochem, but I think primarily what it was anatomy, pathology, physiology. Yeah, a bit of biochem, as I said, and pharmacology.
Okay.
Yeah.
Wow. And what's the pass rate on those exams? Are they quite relatively easy,
Oh,
or
yeah,
do people pass?
pretty high. So I would say like good percentage of like, I think 70%, at least 70% of people would pass.
Oh wow.
On the first go.
Yeah, I think so. I'm not sure if the first go would be, but generally speaking, people who sit the primary exam at one certain point, the pass rate will be somewhere between, I would say like 70%.
That's much better than anesthetics, where anesthetic primary is known to be very difficult, especially the physiology point of it.
Yeah,
And there's a lot of people fail that exam.
I've heard about it. Yeah, yeah. But
Wow.
so primary for ED training, it's broken down into written and Viva. So the written component would be the MCQs, which I found was relatively easier compared to the Viva. Viva is the one where you'll be going in. It's like, remember like the med school, you go in and then there's the examiner and then they ask you questions.
Yeah, like an OSCE.
Yeah, it's like that. Yeah.
But do they, how in emergency you practice like a resuscitation kind of practice, like role plays?
Yeah.
Do you have to do that in that Viva or
No, not in that Viva, just because that's primary. So in terms
Okay.
of like sim type of questions would be for fellowship.
For the final exam?
Yeah. So primary is
Right.
essentially designed to make sure that they have all the basic foundation before actually, starting in ED training. Because it's like basically like entrance exam per se. In a
Exactly. And when do you have to sit the primary by? Like PGY 2 or 3? Is there like a limit or?
I think there is definitely a limit. So I just don't remember the exact time.
But pretty early on, I'm assuming.
Yes,
You kind of
but
have to get it done.
also but by saying that though, I do see people who's registrar year 3, and they still haven't set it yet.
Oh, okay.
Right.
If you're a pretty keen being
Mm,
and you have your heart set on emergency medicine,
yeah,
can you set it prior to
yeah,
getting onto
yeah,
the
absolutely.
program?
Actually, that's a good question because yes, they can do that. So as an HMO, they can actually sit the exam before they actually get onto the training program even. They can do that. Yeah.
Mm.
So they have to worry about one less thing. To be honest, I think primary is more, it's not really related to our practice. It's more so like, the
Mm.
basic foundation, what we had to know in med school type of. Yeah.
Okay.
And my next question
Mm.
is, when do you have to sit your fellowship exams? Have you set yours, Edie girl?
Not yet. So I'm planning to sit it next year. So I have to sit both written and the OSCE. There is definitely a time limit to it, but
Mm-hmm.
I know a registrar that's been registrar for more than like probably 12, 13 years, and the person still hasn't set the
Oh,
exam. So I can't give you the exact time, like when you have to sit it back,
yeah.
but
So can you keep pushing it back until you feel like you're
I
ready?
think you can, unless the college tells you, okay, it's time to really like sit the exam.
You had enough time. You better do it or you're out.
Yeah, but I mean, obviously, you want to sit
And
it early and then pass it.
and how many attempts do you get?
3 attempts.
Mm.
Yeah,
Three attempts.
Okay. So if you don't get in or don't pass after 3 attempts, you're what, out, or what happens
correct. I
after?
think though, from my experience, what I've heard from people is that they, after their third attempt, they could
Mm.
sometimes apply to the college to get a special like condition, like yeah,
Consideration.
exemption, correct, because they went through a situation where yeah.
So just to summarize, basically, there's two main exams in ED training. So primary
Yeah,
and the exit exam, which is a fellowship exam.
yeah,
But along the way, I'm sure you guys have like a consultant-based or like work-based assessments, right?
yeah, that's correct. So it's called, yeah, WBA, short for work-based assessments. Also, there's a
Mm.
research component as well. So as for WBAs, there's a certain number of procedures that you have to perform and then get signed off by the consultants. Those
Mm.
procedures can be anything from doing central line, art line, or intubation, or fracture reduction. And
Mm.
as for the what was the other one? The research component. Yeah, you have the choice of actually doing a research course or actually doing an actual
Mm.
research.
Right. Okay.
Wouldn't it be easier doing a research
Yeah,
course then?
exactly. That's what I did. That's correct. Because
Mm.
if you actually have to do research, then you would have to actually publish to get it accredited.
Oh, so you can't just do a an audit on something and then present it as a poster or something like
No, it
that.
has to be actually published in a journal.
Oh, that's quite intense then.
Correct. So to me, that wasn't quite appealing. So I just went ahead with, yeah, just doing a course.
Mm. Mm. I actually have a question for you. So I've heard, so these are like the, I guess, stories from the emergency registrar and an anesthetic registrar. So emergency registrar thinks that they are better at intubation than anesthetic registrars because the situation is different. Because anesthetics where like patients asleep, everything's like under control and stable, and they literally just intubate them in theater. Whereas in
Mm,
emergency resus, it's chaotic. Like,
mm,
think about trauma.
mm.
Like it's more of a unstable situation, and you have to intubate it. What do you think about that? Is that true?
Uh, okay, so
Just an
I
opinion.
I wouldn't say who's better than who per se, but I think
Oh,
you,
good
you
save. Good save.
but you've just pointed out the big points that yes, in ED, it's chaotic, plus also the patient is generally very unstable. Hence, that's the reason why we need to actually intubate the patient in the first place. Whereas
Exactly.
in theater, from my experience, mostly they're elective procedures. So they're healthy, they're fasted, they're ready to be, technically they're ready to be intubated. And plus you have a nurse, anesthetic nurse who actually knows inside and out about how to get ready. Whereas in ED, you have to find a nurse that's airway trained.
Yeah, that's a bit hard to find. Yeah, exactly.
Correct. And
Yeah.
sometimes, really, it's hard to even find the equipment sometimes, which
Yeah.
is really shouldn't be the case, but it's you have to get everything all set up.
Yeah.
And then plus also it's not just about anatomical difference. So there's difference of what makes an intubation difficult in terms of is it anatomically or is it physiologically. But I think in ED we have patients that are both anatomically and physically like physiologically challenging for intubation. I think that's what makes it tricky. Yeah.
And it's mostly gonna be a rapid induction anyway, in an
Correct.
emergency, right?
Yeah,
But you got
mostly ED. That's correct. Yeah.
yeah, so it's so different. But hey, Andy, we need to get our mate anesthetic Reg on our podcast to rebut this, right? So there'll be another episode.
I didn't say anything that, one is better than the other.
But obviously, I'm not an anesthetic Reg, but if I were to think that anesthetic Reg will say would be that they do this for like day to day, so they'll probably have the skills to whatever the situation is. They'll probably have a great skill to do it.
Also, I'll say
Just
this.
to rebut,
I've got a question. How often do you have to intubate a very obese patient, and what are your success rate as well?
Also, it's not very uncommon to actually have an obese patient, given the fact that, the most of our population, I think we have increasing rates of obesity. So, but when you have a very obese patient in front of you, you will get ready for your best chance. So, you will not be doing direct laryngoscope, but you will be using a gyroscope, which is a video laryngoscope. Plus, there is a specific blade that's designed for obese patients. It's what we call deep blade. So it's actually more hyperangulated so that you can actually get more view. So in terms of intubation, it's not just, the laryngoscope in and then tube in. It's actually usually in ED is laryngoscope and then bougie and then tube in. However, when I see a morbidly obese patient, my first instance would be okay. So the larynx would be very anterior. So I would be putting a gyroscope, which is a video laryngoscope. And then you would be using what we call a stylet, which looks like a hockey stick type of, but the stick is actually loaded on.
Yeah, right. Yeah,
So that
yeah. I know what that is.
Yeah, so you can actually take off the stylet and then put the tube in that way. So, you
I
be
see.
thinking about how to optimize your technique so that you can get the best chance. Because your best goal is your first chance. You want to make sure you get
Yeah.
the more attempts that people go, the larynx will be very edematous. It will just get even harder.
Yeah.
It's like cannulation. The first go is always the most successful.
Exactly.
Mate, you can't compare a freaking cannulation compared to mate.
Oh, I'm just naming
someone,
I'm just naming an example.
Hope you guys enjoyed part 1 of this episode. If you enjoyed it, make sure you give us a thumbs up on wherever you get your podcast, and also join us next time for part 2 of this series.